Education at the School of Public Health. And Chris is also a member of the Lineberger Cancer Comprehensive Cancer Center. Chris is a social psychologist who does a lot of really great work in health psychology. And fundamentally, she looks at the influence of psychosocial resources and risk factors, and how that affects vulnerable, susceptible populations, especially in terms of health-related stressors. Most of this really relates to cancer, but she's also looked at it in terms of other issues such as chronic diseases. And she really has two macro questions. One is she looks at it in terms of individual levels, psychosocial resources, risk factors, which help to determine those populations that are most at risk or in need. And then she also looks at it from a personal aspect, and personal resources and stress factors which can then be applied to these populations to see what types of stress factors that they're more susceptible to. For example, recovering from cancer, or how it might help in decision making. So these are the broad questions, and within these, she's done a lot of really great work being published in just about every top journal in health psychology and public health and health comm. Also has a lot of funds being heavily funded by the National Cancer Institute and American Cancer Society. And her recent work looks at social support groups, looks at health interventions, look at it in terms of factors that help patient decision making, looks at it in terms of giving and receiving peer support in terms of after cancer. So a lot of these really interesting things. I haven't read too much of Chris's work. I've read some, but I don't want to draw your attention to two articles which I absolutely loved a lot. These are two articles I read in health psychology, one of the journals that I follow. And what really struck me was two articles, but both which are so good, but also so, in so many ways, it just talks about the diversity of her work. One looks at it as a very nice theoretical approach, looking at the identification of cognitive and emotional factors in terms of how that leads to patients' decision-making conflict, especially in terms of high-risk breast cancer survivors when they receive information that's not very helpful. I thought that was just a great article. And then the other one looks at it more in terms of social support, parents, families, or kids who are really ill. And that really uses a really nice methodological approach, looks at some nice multi-level modeling. So it's really good, diverse work. And today she's going to be talking about some of her recent work on patient and actor support. So I'm just so happy you're here.
Well, thank you very much, and thank you for inviting me. Yes, my 5-minute elevator talk is more like a half hour or so unfortunately, and there are pros and cons of having a diverse line of research, and one of the cons is you can never describe it concisely. So this is a line of research that I've actually been working on for a very long time, since I was a graduate student, and I became really sort of fascinated with the fact that social support has been discussed for decades, and the research on perceived support, or the idea that the perception that support will be available if you need it, is pretty clear. It's pretty much always a good thing. You want to predict something about social support, you throw in a perceived support measure, you can predict all sorts of stuff. But the research on enacted support, or actual interpersonal transactions, is actually is very mixed. And I think what really drew me to this area, besides the confusion there about why that might be, is that when we talk about what happens in people's lives when they're facing a stressor, and I've been particularly interested in health-related stressors, it's really enacted support, I think, that's very critical. So what do people do when you have this crisis going on, or the need to make an important life change? And how does it help, or maybe sometimes not help, in adjusting or making those sorts of changes? So let me start just by sort of, kind of clarifying that point, that I don't really do research on perceived social support. I'm really interested in this idea that there are interpersonal transactions that are intended to provide people with emotional support. So somebody who listens and tries to understand your problems and provides some sort of reassurance. Information or guidance and advice when you need it. And this is something that comes up when people are facing health-related stressors quite often. And instrumental or tangible assistance. People who can jump in, get you back and forth to your doctor's appointment, help you, take care of your kids and your household while you're in the hospital, for instance. These kinds of things that people can do when you're having some sort of a crisis. It is something that tends to be mobilized in times of adversity or life change, although it's also something that happens on an everyday basis. But I think where it becomes really critical is when people are facing something going on in their lives that's out of the ordinary, and other people need to sort of jump in and help. And ideally, when this happens well, this kind of support does provide people with resources that help them manage the emotional and practical and even cognitive challenges, existential or meaning-making challenges that happen in those sorts of situations. So, again, like I said, ideally, when people provide social support, it can help you make a lifestyle change that you need to make. Think about diabetics and all the things that they need to change in their lives going forward, and those have to be long-term, enduring changes. Adjusting to health-related stressors, and I've been particularly interested in cancer as a stressor, and adhering to self-care or medication regimens, which is something I've become increasingly interested in because adherence to any kind of a medication is really pretty awful, and it has some severe consequences, not only at an individual level, but from a public health perspective. So my overarching goal is to inform the development of social support interventions that actually work. So there are a couple of main types of social support interventions that you tend to see in the literature. One is where we're sort of pulling in or harnessing naturally occurring support. So think for a moment of people who need to start a program of physical activity for whatever reason. People with osteoarthritis, for instance, who would really benefit from some physical activity. You might see some interventions that are trying to pull in their spouses or a friend or a buddy who will walk with them or do exercises with them. So that would be a support intervention that really tries to get at their existing social support and use it for some good. And there are also interventions that try to supplement existing support in the network. So calls or visits from trained professionals. There are a number of these approaches, but in prenatal care, there's research on anxiety or stress during pregnancy and the adverse effects on pregnancy outcomes. And some of the social support interventions in that population have been nurses calling on a regular basis or some other trained professional who can help women with questions they have and help them manage the changes that they need to make when they're pregnant. We also are seeing peer support really just become so popular, and not only in groups but also online, and I'll talk about that a little bit more in a bit. I've been primarily interested in this idea that we can harness or strengthen naturally occurring support, but the research shows that it actually is incredibly complex and hard to do. And in fact, when you look at research on social support interventions, you see a lot of null findings or very short-lived benefits of these interventions. There are lots of reasons why that could occur. Some of them are methodological. And one of the reasons that I'm very interested in is this idea that I think that a lot of those interventions are based on an insufficient understanding of the variation in the effectiveness of support attempts. How does support play out in everyday lives? When is it really actually beneficial, and when does it kind of fall flat and maybe sometimes backfire? And when you think about, maybe times that people have tried to help you in your life, well-intended attempts at emotional support or some help with some task or some information or guidance, the times when it was truly helpful versus the times when it really wasn't. And so that's what I'm interested in. The idea here is that when social support backfires or falls flat, when it's ineffective, it actually does not provide the resources that help people cope with that life change or health stressor. And my colleagues and I think that that may be part of what lies behind social support interventions that don't work in the long term or that don't work very well, because we just don't know enough about how social support plays out in everyday life, what makes it effective, what makes it ineffective. So, and I apologize in advance for we'll probably hit some funny formatting things because this is created on a PC and showing on a Mac, but so what is ineffective support? What does it do that actually can work against people? Well, it can create a sense of guilt or obligation. There's research showing that sometimes when people receive support, they do feel obligated or guilty. Sometimes it constrains their freedom to act. Somebody who provides a particular kind of support, that may mean that you have to do something or behave in a certain way that maybe you wouldn't have, but it would feel wrong maybe to not accept that support, or you want to not be ungrateful. Or it might just be such an important form of support that you can't turn it down, and yet it constrains your freedom to act. Certainly, we see a lot of feeling smothered or overprotected in, say, chronically ill populations or in populations, for instance, cancer survivors talk about this quite a lot. And it can also communicate that the support provider sees you as being incompetent, or it can give people a sense of inadequacy to have to get support. Imagine a support provider jumping in so fast that you haven't even had a chance to try something on your own, and what that might mean to you. Or imagine somebody really just trying to take over a problem and not allowing you to work through it on yourself. It may send the signal, and quite often does, that that person does not view you as competent to handle your own problems. So in our social support effectiveness theory or framework, we see these kinds of effects as being indicative of ineffective support. And when they happen, not only does that support not have its intended benefits, but it can actually work against you and increase your stress burden, actually causing people to have more stress or more difficulties instead of less. When support is effective, though, we do think it would actually convey those resources that help people cope with the practical problems, the emotional problems, and the cognitive or meaning-based problems that they have during times of great life change or a severe stressor. And when they cope better, ideally, they should be better adjusted psychologically and have better physical health outcomes as well. So we began this research basically by defining social support effectiveness because we wanted to create a way of measuring it. There was no measure we could use, and without a measure, we couldn't even begin to study it. So this is the definition that we came up with after a review of theory and literature. We've been working with this definition for quite a while now, and it's working pretty well. But we see effective social support as involving both the quantity and quality of emotional, informational, and instrumental or tangible support. And ideally, it is appraised by the recipient as approximating their need in terms of its quantity and its quality. And I'll talk about that more in a moment. But also, it's appraised as not causing the negative consequences on views of self or provider or the relationship, the kinds of things I spoke about, feeling incompetent, feeling obligated, feeling like the person doesn't view you as somebody who can manage on your own. So using this sort of operational definition, we decided to begin studying social support effectiveness, and our overarching hypothesis is that we can, in fact, measure the variation in the effectiveness of support, and that when we measure it, it should be an important determinant of whether social support has beneficial effects, null, or actually detrimental effects at times. And we're looking quite often at physical health or psychological or psychosocial outcomes. So we have a 25-item measure. We've tested it in a variety of populations. It started out as an interview, now it's a questionnaire. But one of the sets of questions in it asks about the quantity of emotional, instrumental, and informational support. Does it approximate your level of need in terms of the quantity you receive from this person in general? So getting too much actually would tend to make people feel smothered or overprotective, and it throws a relationship into a state of being inequitable. And likewise, receiving too little support for what you think you need can make you feel neglected or unloved, like the person's not paying attention to your needs or doesn't care about them. And again, it can throw a relationship into being inequitable. This form of inequity is called being under-benefited in a relationship. And it's actually, of the two kinds of inequality, more problematic. It's worse when you feel under-benefited than when you feel over-benefited. But in the long run, ideally, there's give and take in a long-term relationship. And we are talking about relationships like marital relationships or different kinds of partner relationships or family relationships that are very long-term. Measuring the effectiveness of the quality of support was much trickier, and it actually takes up the vast majority of the questionnaire. But basically, again, we were guided by theory and research. And what we do is we measure the extent to which the support, the emotional, instrumental, and informational support, matches somebody's needs in terms of its quality. So is it the right kind of support given in the right way at the right time is basically how we think about it. Was it hard to get? Do you really have to, pull it out of the person and they don't seem to be forthcoming with the support? Well, that sends a message. Or is it pretty easy to get? Do they jump in and spontaneously offer it? That also sends a message. They're paying attention and they care. Is it sensitively provided? And this gets at something I'll talk about in a little bit. This is a really kind of a skill-based behavior. Getting support and giving support is based on social skills. And we also measure those negative byproducts of receiving support for the self and views of the provider and relationship. The idea is to keep those at a minimum. When they're at a minimum, social support is more effective. Now, I don't want to spend too much time on this, but we do think that it's important to understand the antecedents of social support so that we can eventually devise a way to intervene to improve it. So what do you do to make somebody better at receiving social support and giving it? And we do think this is something that involves both recipients and providers. There are dispositional factors that come into play here. Do people feel like they should provide support to somebody who's struggling? Or do they feel that that person really needs to cope with that on their own? There are individual differences in that. Do people feel like they should tap on their social support network or that they should solve problems on their own? Those kinds of individual differences are very important. But beyond that, there are also social skills that are critical. You have to be able to, if you're a provider, determine the support that the recipient needs. Figure out the best way to provide it and then carry that action through sensitively. Can the recipient, on the other hand, understand what he or she needs and somehow communicate that and respond appropriately when that support is given? And both of those things we believe are important, and we do have some evidence for parts of this model. And you'll see there isn't complete overlap between the provider's perspective and the recipient's perspective. They are definitely distinct perspectives, but they do influence each other. So, most recently, we've been studying social support effectiveness in people who've been treated with a stem cell or bone marrow transplant. And this is a very challenging treatment, very toxic treatment for people who have a hematological cancer. This is something like leukemia or lymphoma or multiple myeloma, although it is treated for an increasing number of other diseases as well. People who undergo this risk are not only this treatment are not only at risk because of their disease, their diagnosis, but the treatment itself is very toxic and very risky in its own right. They get high-dose chemotherapy very often, and most often, literally such toxic doses that the stem cell transplant that's given to them afterward actually saves their lives because it completely knocks out their immune system, kills off their bone marrow, and it has to be reconstituted. Sometimes these individuals also get total body irradiation, again, a lethal dose of it, and then they're then saved by an infusion of stem cells. It's a long, drawn-out treatment. People are very debilitated during the treatment and afterwards. It takes a long time to get back to something resembling normal. So they have multiple challenges. Self-care that has to continue for months, monitoring symptoms that may indicate relapse or secondary cancers that come from the treatment. A lot of practical problems. The work life is completely changes quite often. Many people don't get to go back to work, or they have problems when they do. But during treatment, the family finances are also disrupted because it's an incredibly expensive treatment, and sometimes insurance doesn't cover all of it as well. So there are a lot of problems that they have during treatment and afterwards, and we think that if social support is good, that it actually would help them get through this process with minimum problems. And people are actually quite resilient, but there is a good-sized subset that has continuing problems for years and years, and sometimes for their entire lifetime afterwards. So there is evidence for benefits of social support after transplant. It's mixed, though, but it's also a very mixed bag of studies. So most often it's emphasizing perceived available support, which I mentioned earlier. It's just this idea that if I needed support, I would get it. So very little research on what actually people do during and after treatment in terms of social support. And most studies have focused on either general support without specifying the provider or family support. But most people are married or partnered, and most often the support provider is a partner. So that's why we have, in this early research, really focused on the partners as support providers. There's been very little research on partner support, and really no effectiveness, research on the effectiveness of support. Yet there is evidence that support does vary in its effectiveness. So a study on common problems people report after transplant. A lot of people saying, other people don't understand my needs. They don't know what to say or how to treat me. They baby me, or they're overprotective. They have problems communicating with their partners during and after transplant. And they have concerns about the effect of their transplant on their relationship with their partners. There has been some research on problematic support prior to transplant and its effects on people's adjustment afterwards. And it's not very common that you see problematic support, but when it does happen, it's important. It has some strong adverse effects on patient functioning. So I want to talk about a first study that we did. And the goal here was to consider the importance of studying the effectiveness support over and above support frequency. And we studied support frequency because that is the typical way that enacted support is measured. How often did you get this? How often did somebody do that for you? And it really just gets at this idea that if it happens more often, it's considered to be better. So the more you can get, the better. And we really questioned that because we had this idea that, well, getting more bad support would actually not be all that helpful. So we looked at this in a study of 230 transplant survivors who were about 1 to 3 years post-transplant. And as is, this is actually a very typical demographic for this sample. Mostly white, mostly married, high degree of college education, moderate to high income. There are lots of reasons. This is actually similar to sort of the national picture of who goes through transplant. There are people get filtered out along the way, and by the time you get to this point in the process of this treatment, a lot of people have not had the opportunity to get it. So these, again, are people who are treated for some very serious diseases. We used a standard measure of enacted support that was developed for use in cancer. We used our social support effectiveness measure, and then as an outcome, we looked at generalized distress using the brief symptom inventory. And this is where I think we're going to have problems with formatting. I thought I fixed it, but it reverted. Luckily, I've summarized the findings there, and what we found is that there were some demographic predictors of distress. Women were more distressed, younger patients were more distressed, people with worse physical functioning were more distressed. Nothing surprising there. It's very consistent with the research. The frequency with which people reported receiving partner support was not predictive of distress, and that's also fairly typical. As I mentioned, there are a lot of null findings when it comes to enacted social support. We did find a positive effect for partner support, so that the more effective your partner support, the less distress you had. So that was a beneficial effect that we had hypothesized. The really interesting finding, though, was this interaction. And let me just show you what that looks like. So basically, there is a main effect of social support effectiveness. When people got ineffective support from their partner, they tended to be more distressed than when people got effective support. But the really interesting thing was its combination with the frequency of support. When people who got ineffective support from their partner got more support, they actually had greater distress. When people who got effective support from their partner got more of it, the amount didn't matter. Their distress was low, and it wasn't affected by the frequency with which they got it. It was really important that it was just effective. But it was important, the frequency, the amount was important when the support was ineffective. Getting more was actually worse than getting less. So the summary, I just described it, but we were really interested in taking that a little bit further. So that was something that kind of bolstered our belief that we had tapped into something important about social support. And we wanted to also look at the idea of stress buffering. And this is really sort of very important to the idea that when people give support, it should also provide resources that help people manage the effects of a stressor. Getting more support should help you manage that stressor better. And in our point of view, that would only happen if it was effective support. And we wouldn't expect to see that sort of buffering if it was ineffective support. And in fact, there's very little, even though there's a strong theory supporting the idea that this kind of emotional support or this kind of social support should buffer the effects of stressors, there's very little evidence for it in the literature. And people have sort of stepped back from even considering it. It shows up for perceived support, but not for enacted support. So this is actually... our next study was with an entirely different population, still bone marrow transplant survivors, but in a different study. And we specifically focused on buffering effects. So this was 228 cancer survivors. Again, about half women, half men, mostly white. Great age range. And in terms of the other demographics, a similar fairly high level of education, fairly high level of income. Most of them had received what would be considered to be a less problematic kind of transplant. They get their own stem cells rather than a donor's. This was true in the other study as well. And again, we looked at generalized distress as the main outcome. And for our stressor, these people were 2 or 3 years out of transplant. So we wanted to look at how the problems they were already having with transplant recovery were sort of compounded by negative events that happened recently in their daily lives. So we had a measure of negative life events. It's a measure by Saracen that's quite often used. It's just a count of how many things they've had happen in the last 6 months. And also, again, looking at the effectiveness of caregiver support. But this time, we had people who had a partner, either married or not, report on the effectiveness of the support they got from that person. People who did not have a partner nominated the person who was their closest support provider during and after transplant and reported on the effectiveness of support from that person. And in this case, the negative life events were predictive of distress. The more they had, the more distressed they were. Social support effectiveness for the caregiver was important as well. Getting effective support from the caregiver predicted less distress. But we did actually here see a 3-way interaction. And let me show you what that looks like. What we found that we did find the buffering that we expected, but only when the support was from a partner. So over here you see that when people got social support from a partner that was relatively ineffective, they actually had more distress as their level of life stress got higher. When they got effective support from their partner, the number of negative life events didn't matter, didn't have an association with their distress. For people who did not have a partner caregiver, however, the more life event stress they had, the more their distress, regardless of how effective their support was. And we we have some ideas about why that might be the case. You know, one of the things is the partner lives in the household. There's lots of opportunity to provide support, effective or otherwise, whereas other people don't live in the household. There's a lot less contact. We think that might be important here, but we have not yet been able to follow up on that finding. We did, however, find the buffering effects of social support that suggest that when people get more effective support from their partner, it actually does help them cope with or reduce or mitigate the adverse effects of some life event stress. So let me talk just a little bit now about implications for interventions, because that's really where we want to take this work next. We're still trying to understand what it is that predicts when support is going to be effective versus ineffective. And we've got lots of qualitative data. We've got lots of data that we're sorting through right now, and we're finding some interesting things, all of which lead us to the conclusion that if we can somehow make social support more effective, it would benefit people. And then the question is, well, how do you do that? Because it's not an easy task. This is a really complex phenomenon. So we want to be able to predict when social support from a key support provider, like a partner, but sometimes other people as well, we suspect, is likely to be effective versus ineffective. And when it's ineffective, target those at-risk individuals or dyads for some sort of an intervention that increases the effectiveness of their support. And one thing that we're thinking is that the context of the intervention will make a difference in what that intervention looks like. So for our transplant survivors, we would like to catch them before they go through transplant. It's sort of a time-bounded phenomenon, though. They're going to be in the hospital for a month or 2 months. They're going to go home. Most of them are going to do pretty well by about 3 to 6 or maybe 9 months. And then there's going to be a small subgroup that continues to have problems. But really, they're already burdened before they go through transplant. We can't do an 8 or 12-week couple session with them that deals with all of their relationship problems and their whole history of social support that went right or went wrong. So we think that we'd have to jump in with something very brief, maybe some brief training and skills or addressing problematic patterns in expectations or appraisals, possibly using a cognitive or behavioral sort of training approach. For people with really severe problems, people who we don't think would respond to a short-term intervention, we think probably that would mean we'd need to supplement their support with, you know, somebody else who could come in and kind of fill in that gap, what they're not getting from their partner. But there are lots of populations dealing with health problems that require longer lasting change. And again, going back to the idea that people with diabetes have to manage their illness for the rest of their lives, or people with osteoarthritis need to increase their physical activity and lose weight, and that's an ongoing process. Here we think we can do a longer term intervention because we really have to change the social support effectiveness going forward, and the change has to be maintained. So we might be able to do something a bit more in depth. So again, we think a skills approach and a cognitive approach that deals with support appraisals and expectations and beliefs might be critical. But we also think that we may be able to get at some problems within the relationship, some sort of things that stem from a history of problems, and that as long as people are staying together and their partner is in their household or their support provider is a long-term part of their lives, then getting at really effective support will also mean addressing some of those problems. So this is not a small task, and it's going to be very complex, but the potential payoff from a public health perspective is big. Now, what about mass communication? What I've been talking about is one-on-one support, dyads working in everyday life, dealing with things that are happening just as they go along, trying to recover from transplant or deal with whatever life change they've got. I'm really fascinated with this idea of peer support and how it's become very, very popular. And of course, a lot of it is happening online these days. And I put up some examples patients like me, I think probably a lot of people are familiar with, people get online, they share this detailed information about their medications. They give each other advice about dosages. I mean, it's really incredible what they're doing for each other. A lot of emotional and information support going on here. But for cancer patients as well, there are lots of places where they can go and link up with people who've been through a similar type of treatment to get information and advice. And the vast majority of people find this to be very useful. But we definitely see that there are some potential pitfalls here. So now, having spoken with a lot of bone marrow transplant survivors, I could tell you, many of them have talked about situations when they've connected with a peer or they've gone online to learn about experiences with peers and describe getting very scary information that they think is not accurate and very harmful, and having to really disengage and stop talking to or looking up peer experiences altogether because it was such a bad experience. So we know that it can go wrong. We did a qualitative study with the first set of stem cell transplant survivors, and we found that nearly a quarter of them reported having some sort of a bad experience with peer support. And I should say that nearly all of them got it, and they had sought it out in these ingenious ways. My neighbor's cousin had transplant, and that person put me in touch, or I went to this meeting of people who have leukemia and I got to talk with people, or I was talking to the person sitting next to me in the waiting room, and we became friends and started emailing and talking on the phone. So almost everybody got it. Often they were connected in person, but very often as well they used some sort of media. They were on the phone, they were text messaging, they were emailing, they were going on the internet to chat with each other. There was this really fascinating study that I think is only tangentially related, but I think it speaks to the idea that when people go online and think they're getting benefit or giving benefit, they're not always right. This has just come out, and this was a study of postings in Facebook and how positive and negative they were. And this set of researchers found that when people have low self-esteem and they were going online because they wanted to connect with other people and they saw this as a very doable way to do that, other people actually didn't find them very likable because when they have low self-esteem, their Facebook posts were actually quite negative. And that the negativity in their posts led them to be unlikable. And this was coded by the researchers. People with high self-esteem had a lot of positive things in their posts. People actually found them to be much more likable. And yet the low self-esteem people thought that what they were doing was beneficial. Now, this was people who were going on and communicating for whatever reason, not necessarily offering peer support. But Facebook is used for peer support, and other kinds of outlets for peer support online have the same sorts of things going on. People going on with the intention of getting information but also sharing information, and not always doing it very well. So we really need to understand more about what's going on here and how this actually could be an area for intervention as well. And we do think here that context matters too. So when people are getting and giving peer support online, quite often it involves emotional support and informational support. So we're not seeing tangible support. They're not going to come and give each other a ride to the doctor's appointment or go with the person or things like that, lend them money. There's less of that kind of thing going on. So really we think that the effectiveness of emotional and informational support may be key here, although there probably are some also negative consequences that we need to pay attention to as well. Feeling obligated, I'm not sure. Feeling guilty, I'm not sure. It might be a completely different set of things that we have to think about. But I think a really interesting challenge as well is that you're not going to be able to intervene with the couple in the same way that you would be able to if you're dealing with a couple or a dyad. So I think ideally you want to change the behaviors and the cognitions of a support provider and a support recipient. Well, here most likely you're only going to get to do one or the other. if you are devising a peer support intervention, you can understand who is or who is not good at providing peer support and possibly provide them with training that would enhance their ability to provide effective support. When you're dealing with recipients, people who are going online and getting support through different kinds of chat rooms or bulletin boards or whatever, you might be able to teach them skills as well, because we do think, again, that skills underlie the ability to receive effective support. So do you know what you need and how those needs change over time? Can you express them? Can you disengage from a situation where you're not getting effective support? How do you do those things? And we think possibly expectations and appraisals come into play here. I expect I expect everybody to jump in and offer me support. I put my post out there and nobody responded. What does that mean for me? Can we moderate those kinds of expectations and possible negative effects so that people are less likely to view really well-intended attempts to support them as beneficial rather than a sign that people don't care or they're not worthy or whatever might stem from that? And I think we'd also need to have people learn how to recognize and disengage from those problematic sorts of situations that certainly arise in online peer support situations, where they really don't have much control over what's said, but they can get out of that and find another source or another person to communicate with. So this is speculation at this point. It's an area that we would like to go into and that we've been very fascinated by. But we have to get the funding to move in that direction and do some research to understand how is peer support online very different than the kinds of things we've been studying. So before I finish up, let me just thank my collaborators. As I said, this is years worth of work, starting with my graduate school days at UCLA with Chris Dunkelscheder and going up through my collaborators on all the stem cell transplant research funded by National Cancer Institute and the American Cancer Society, which we've been just very, very grateful for. And thank you very much, and I'll take any questions. Can you be ready first?
What's the difference between effective and ineffective support from a partner?
Well, I think the way that this actually step back for a moment and kind of picture the support you've gotten from your own partner. And I think the key here is thinking we're really interested in well-intended attempts to support. So informational support that is not perceived to be helpful. So somebody who really tells me how to get something done that I need to do, and that information actually helps me get that thing done, versus information that tells me to do something that I can't even control, for instance. Well, you should have asked the doctor this, and the doctor should have done that, and why didn't that happen? And that's not very helpful, but next time you go to the doctor, ask this question, and why don't we think about the other questions that you might want to ask? That's actually quite helpful. Emotional support, there's a whole research literature on perceived partner, oh gosh, now I'm going to blank on the term, responsiveness. So does your partner truly understand what you're trying to communicate and validate it and respond appropriately, versus act like you're being unreasonable when you try to share your concerns? There's also research on social constraints. How do people react when you try to share your thoughts and beliefs or feelings about a problem? And sometimes they don't react very well. So we would say that would be ineffective support. For tangible support, I think that's probably a little bit easier. I mean, my husband did the laundry, and oh no, this is going to be on YouTube, isn't it? And he washes things together that shouldn't be washed together. I mean, there's lots of things where instrumental or tangible support is actually not quite what you would like it to be. And oh look, all my socks are pink now. So ineffective versus effective. I come home and oh look, the laundry's all done and it's folded and it's right there. Isn't that nice? I wouldn't have expected that. Dinner's done. That's really great. So I think there are lots of ways it plays out in everyday life where it's effective versus ineffective. Is that? Yeah.
I'm just curious, in dyad, it is male, male, female, 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 male. I would think there'd be a lot of differences there.
You know, we have not looked at this. We actually have not restricted these samples to heterosexual couples, or and when we do have, say, female-female dyads or male-male dyads, it's family relationships or friendships, not partners. We just have not had any same-sex couples. We do know over and over again that women provide more effective support. It's something we find over and over again. It's very consistent with the literature. But I think it's a really interesting question we just don't know the answer to right now. How does the gender of the couple matter? Yes?
I had trouble teasing apart the idea of perceived support from actual support, and partly because, maybe I'm wrong, but it's measured by self-report either way?
It is measured by self-report. So, and this is a problem that we really sort of struggled with. So, perceived support asks questions like, if you needed somebody to loan you some money, do you have somebody who would do that? Yes. Pretty much always good. Enacted support does ask about things that happened. So in a way, it's sort of appraisals of things that happened. So there is a very strong perceptual component. In a way, we think that that's very important, even though it's something we typically have to sort of work around. It would be nice to be able to stand back, and we could probably do this, watch an interaction and judge whether we think it's effective. And we can, certainly there are lots of research paradigms you can use. Couples coming into a lab and they're videotaped and you're coding their interactions. Early on, we actually collected data from partners and pregnant women, and we were mainly interested in pregnant women as recipients of support from their partner. We had a family member or friend weigh in on how effective they thought support was when it came from the partner to the pregnant woman. It predicted nothing. It was sort of related to women's appraisals of the effectiveness of support, maybe because usually that other person was a sister or the mother, and they talked about how the partner was good or not so good at various things, but it didn't predict anything. So, and we really had high hopes for maybe a close friend or family member, somebody who's really familiar with the couple, might have this really unique and interesting perspective. And I think what happens are those appraisals and expectations, and there's actually a pretty strong research literature in relationship science saying that we are very good about appraising our partner's behaviors positively in a positive relationship, or when we feel good about our partner. And there are actually motivated reasons to see our partner in a very favorable light and our partner's behaviors in a very favorable light. And what goes on in the mind of the support recipient whose health we're really concerned about or whose behavior we want to change, I think is really critical. So yes, so while it is appraised, it's not an objective view of the effectiveness of social support. I think the appraisal actually is important for what we hope to do with these data.
Just one small follow-up.
Sure.
Do you know the correlation between, say, the recipient and the provider?
Yes.
And in terms of their opinions of effectiveness, do they correlate?
They do, but not very highly. And it's sort of typical. It's like in the 0.3 something range. They don't share much variance at all. And actually, I will say, there is a very, from the pregnant couples, there was a very funny finding, and that is, what is it about the woman that makes her appraise her partner's support as effective versus what is it about the partner that makes him appraise his own support as effective? And with the women, it was if their partner had these great caregiving skills, there's this caregiving scale that's related to the attachment literature. If he was a good, I think it was conflict management, if he was empathetic, actually, these kinds of things. Partners thought their own support was effective when their pregnant partner didn't seek support and was relatively independent and really good at conflict management. So it was basically, I think they really didn't get much feedback, and with no feedback, they were just assuming that they were doing great. So I think they're just incredibly different perspectives, and that's why we don't see a whole lot of overlap. Yes?
Can you talk a little bit more about the expectations that the patients have? And my assumption would be that they typically would be fairly high for the support they would get, although in some cases they could potentially be low, in which case their support would meet their expectations.
Now, we haven't actually collected data on this, but we have lots of qualitative data, and I can tell you what we've seen in the things that people have told us. So we have qualitative data on social support from the partner before, during, and after transplant. And what we find is that most often people have high expectations that their partner will be incredibly helpful, and most of the time the partners are. And they come out of the situation feeling closer and feeling grateful, and and it's a really profound experience. We do see sort of a minority of people who knew that going in that their partner was not really good at providing support, and while it was difficult and disappointing, and there maybe were some lingering hard feelings, at least they knew that their partner just doesn't really do this very well. And then I think we've got a very small number of people whose partners just didn't step up to the plate, and it took them by surprise. And those people will say that they're grateful, and when you listen to the tapes of how they say it and actually go through their story, you can see that it's a problem. It's a problem for the relationship going forward. So I think that expectations may be incredibly important. We don't have hard data on that yet, other than these qualitative data. Yeah.
A very brief question. Did you measure for the ways in which this reflection itself could have shifted the way social support was given?
No, we haven't. What we're trying to do right now is get a longitudinal study started where we have couples who have to meet some sort of a challenge. So we have a couple different versions of this, but one is people with osteoarthritis who need to increase their lifestyle physical activity. So they have to make a long-term change. It's really hard to get people to do this, especially when they're older and they have knee pain or hip pain. And we think that if they get effective support from their partner for doing this, it can really help them not only make the change but maintain it. So we want to do a study where we get at some of these issues, which couples are likely to actually work together pretty well and which aren't. And that's where we'll be able to look at some of these more prospective relationships and predictors within couples or dyads working together. But we haven't gotten there yet, unfortunately.
And you think maybe you'll be able to follow people who are getting ineffective support and see if that reflection of ineffective, this is kind of what I'm interested in, what happens for the people who don't have the resources, because we see how well it turns out for those who do, but for those who don't, does the reflection process give them a chance to seek it out in other places? There's couples that were like, gosh, they didn't step up, but the reflection act gives them a chance for, okay, I need to
Yeah, and I think very often people in fact do that. And we do have some evidence, and it's not with social support effectiveness, that when the partner, and this is in a study of actually parents of children undergoing bone marrow transplant, and there's been a finding in the research for a long time that friends and family and other support providers cannot fill in for poor partner support. But we actually found that wasn't the case in this situation, and we think it was because the partners cut each other some slack. I don't expect my partner to be able to meet my every needs when he also is coping with our child's serious illness. And so in that case, friends and family member support was actually incredibly important. And another example that we've thought about is, my partner wants to walk with me, and that we're going to get up and we're going to walk 3 or 4 times a week, and it'll be great. And then the partner gets out there and walks too fast, or says, no, you're supposed to go faster, and it really becomes aversive rather than helpful. Maybe they'll pair up with a neighbor or a friend. It seems likely, it's just speculation, but I think it probably would happen. Either that or they'll give up altogether. Yeah. Mm-hmm.
like-minded people get together and they create a website. So maybe patients can expect like very useful information, but like somebody who wants to get like emotional support that they might not get from that website, or maybe that will be different. So it will be opposite or something. So
yeah, I think that's a good question, and I don't really know. Now, when people, there's a lot of emotional support that goes on those websites, and there's some research, and I'm not completely up to speed on where the research now stands, but certainly informational support is available. Now, whether it's always good and relevant information, I don't know. I think there's some indication that it's actually not so bad, and others where it actually is, and I don't know that we quite know yet. I'm not sure what the emotional support looks like, and I'm not sure, does it mean, do you ask for a particular kind, or if you ask for it, will you get it? Or, if you went out there and said, look, I just need to feel hopeful today, somebody tell me something good, I suspect that people would jump in and do that, but that means you've got to know to ask for it. So, I'm just fascinated by this. I'm really not sure how it'll play out, so I think it's going to take a very targeted study to figure that out. Well, thank you very much.